The next case is a 81-year-old female patient. She was admitted to the hospital with abdominal pain. Subsequent imaging studies showed a cystic lesion in the pancreatic head. The red arrow on the image indicates the cystic lesion found on MRCP, and Professor Feiss will now show you the EUS examination of the cystic lesion.
So, hello, good morning. I'm already started with the endoscope. It's an Olympus GF1 CT 140 echo endoscope, a linear one. And I decided to take a linear one endoscope in order to examine the pancreas. It's for me a little bit more convenient. So if you can change to the echo endoscopic picture, I start to show you the anatomy. If I start the pancreatic examination, I start, if a cameraman can show here please, to the endoscope. Can you switch to the endoscope please? I start in, I say 45 centimeters plus minus, and she's a little old lady, and she has only 150 centimeters, so it's 42 centimeters. Then the endoscope. Here you see my finger, please. My finger is 45 centimeter. Geh mal hier auf meinen Finger. Aber im Bild on 45 centimeters. Here, 45 centimeters. And if you now switch to the echo endoscope picture, you can see here the body of the pancreas. And I can turn a little bit to the right side, and I can follow the pancreas towards the tail of the pancreas. And if I turn a little bit more, I come here to the spleen. Now I go back. Here's the kidney, the left kidney, and above the kidney again the body of the pancreas. And you can see in such a case we have several features to discuss. First feature are there signs of chronic pancreatitis? And the next step is there enlarged enlarged pancreatic duct. So if you can see here this parenchyma of the pancreas, it looks, in my opinion, very, very normal. And we can see the pancreatic duct here very, very small. If you measure it, it's, I think, only 1 or 2 millimeters. Yeah, 1.4 millimeters. So an absolutely normal pancreatic duct. Next step I can show you here, beside the pancreas is the left adrenal gland. You can easily see here. Yeah. Bertrand Napoleon is showing you. And between the pancreas and the left adrenal gland, you can see the vessels flow here. Yeah. You can see a splenic artery and splenic vein. So we have a complete anatomy, and I go back to the pancreas now. Yeah, thanks. And I follow the pancreas a little bit more in the direction of the head of the pancreas. On the left side you can see a small bowel. Yeah. So I follow the pancreas a little bit more and more and more, and now you see the pancreatic duct very, very long. Also not enlarged, so there are no signs of a main duct type IPMN, with a normal duct without a color Doppler sign. So I go a little bit further in the direction of a pancreatic head, and you see here again the pancreas and the pancreatic duct, and you can see here parts of the duodenum, I think. So, but here may be the beginning of a cystic lesion. I'm not sure. Can be, but I'm not sure. Now it's outside. So from here, from the stomach, we cannot delineate the lesion. So I have to switch. Here's the portal vein. Another nice picture. And just a second. But also from here, no possibility to show you the cystic lesion. So I have to change my position and go here the confluence, splenic vein, mesenteric vein, and portal vein. No? Okay. So now I change my position and I go to the endoscopic picture. And now comparable to ERCP, I follow to the antrum, and here I see the pylorus, and now I pass the endoscope to the duodenum, and I go to the second part of the duodenum. So I stretch the endoscope, and in my examination I fill the balloon, you can see, and when I deflate the air, and I go back to the endoscopic picture now. And now you can see from the right side coming up the pancreas. I pull back the endoscope a little bit. Here's the duodenum again on the left side, and on the right side comes the pancreas. I pull back the endoscope. Here comes the duct, part of the pancreatic duct. And here comes the cystic lesion you already saw in the MRCP. No? So we can enlarge a little bit the picture. Yes, thanks. So again, here normal pancreas, no signs of chronic pancreatitis. And here a cystic lesion. We can put the Doppler in to show that this is not a vessel. Okay. And now we have to discuss what kind of lesion is it. A conventional pseudocyst? I don't think so, because there are no signs of chronic pancreatitis. A cystic tumor, yes, can be, and as you already heard, there are several kinds of cystic tumors, and IPMN is one of the favorite ones, and there are criteria for main duct type IPMN and branch duct type IPMN. Main duct type IPMN is a tumor which an enlarged pancreatic duct with mucus inside the pancreatic duct leading to the dilatation of the pancreatic duct. And branch duct type IPMN is an IPMN without a dilatation. And Bertrand is measuring the lesion. It's nearly 2 centimeters. And if you look in this area here or in this area, you see some small, here can you very, very clearly see one small duct going out of a cystic lesion. Can you see? Here, yes. Yeah? And I can suppose that this is the communication between the cystic lesion and the duct. So we have, in my opinion, is a branch duct type IPMN leading to a dilatation of a certain area of the pancreas leading to this cystic lesion. And the next criteria of such IPMNs is the size. And the size is less than 3 centimeters. And here in the upper part we have another communication to the duct. You can see in this area here. And so we have a criteria, the size less than 3 centimeters. We have the communication with the duct. And the next step is to exclude some nodules here, because if we have a solid structure, it may be kind of malignant tumor. But here you can see this absolutely clear lesion, no solid areas. You see no nodules. We have less than 3 centimeters. We have no communication. We have a communication to a side branch duct of the pancreas. So in my conclusion, it's a branch duct type IPNN without signs of malignancy, and the lady is more than 80 years old. So in my opinion, this is a case for control, and we would suggest the patient to come back in 6 months again and to check with echo endoscope again to look whether there are some changes with solid lesions, or to check whether there is an increase in size of this lesion. We can discuss to do an FNA, but if we don't change our protocol in this patient, there is no need to do FNA. FNA could help us to show that this is mucus inside, but I'm really sure without without FNA that this is IPMN of a branch duct type. Again, you can clearly see here the communication, the small duct here going to the cystic lesion in this area. So
I have one question for you. The international consensus guidelines that were published by Tanaka and many other colleagues say that one other indication for surgery is symptoms. And you told us this woman has abdominal pain. So in this case, would abdominal pain be an indication for surgery?
But I asked the lady before, and she has an absolutely diffuse symptomatic. Yeah? She has abdominal pain, sometimes in the right upper abdomen, sometimes in the left lower abdomen. Yeah? So I'm absolutely not sure whether this small lesion, less than 3 centimeters, has something to do with abdominal pain. I think she has abdominal pain due to some other reasons, and during the examination of the lady, this lesion was followed out. And I would suggest the lady not to do an operation now, but to look after 6 months again what happened with this lesion, and then discuss again. If the lesion becomes bigger, or if there are signs of malignancy with solid areas or something else, there might be a clear indication for operation, but not now.
We have a question from the audience. Can we get the left microphone on, please?
Hello, this is Bill Brugge. I was wondering if you thought that the main pancreatic duct was dilated just proximal to the pancreatic cyst. And if the duct is dilated, do you think that there is obstruction, or do you think that there could be main duct IPMN?
I didn't understand the question completely. I think the question was whether there is a dilated pancreatic duct, and whether it's the main duct IPMN or it's a compression of the duct. Here you can see the main pancreatic duct, yeah, and it goes to the area of the papilla and becomes a little bit wider.
What is the diameter?
Here it's the diameter, it's 4 millimeters. Yeah? 4 millimeters.
Do you think that's dilated?
So it's a little bit dilated, yeah, here, and here's the communication to our cystic lesion here. But in my opinion, here you can see the normal pancreatic duct here, yeah, and in my interpretation, it's not a main duct type, it's a branch duct type, and we have no mucus inside the main duct, so for me it's a branch duct type IPMN. We can discuss a mixed type, but I think it's a branch duct type IPMN.
That's a very good point, because it's not uncommon that you see a slightly dilated main duct in this setting, and that's a critical difference, because main duct IPMN is operated on and side branch is usually not operated on.
Yes.
In the Tanaka consensus guidelines, the definition of main duct dilation is 6 millimeters.
Yeah.
So even though technically this duct is dilated at 3.8 millimeters, normal should be 3 or less.
Yes.
It doesn't meet the Tanaka guideline criteria of 6 millimeters. So I would agree we would not classify this as main duct IPMN according to those guidelines.
Okay, thanks.
One more question from the audience.
One more question. We often advise surveillance of this kind of cyst in 6 months, in 12 months, but how often, in your experience, there is something wrong with the cyst on surveillance examination? So you examine the patient in 6 months and you see a solid component nodules. I think that's quite infrequent.
As I understand, the question was how often I make the control examination and how often I see something.
Not really. How often do you see on control examination something which is
changing,
indicative of malignance? A new change, a significant change.
In cases of side duct type IPMN, the changes are really rare. Yeah? Normally you see no change after six months. Sometimes you see some mucus, you see a little bit another dilatation of a duct, yeah? And then you have to discuss. In younger people, if I have a 30-year-old lady, for example, I make not 6 months, I make 3 months. In older patients, I make the first control after six months. But it's rare. It's a rare case that you see some changes after 6 months. Some more questions?
You follow this patient, will you follow them with endoscopic ultrasound or with other cross-sectional imaging such as CT or MR?
I suggest to do in 6 months EUS again, because EUS is the most precise method to discriminate between these changes. And if it is in 6 months normal, we can do with another cross-section imaging.
Another quick question. It looks almost at the approximate 8 o'clock position in the cyst. Was there a very small mural nodule, or was it a small amount of mucus in the cyst?
In the 6 o'clock position? Here?
The 8 o'clock position. There's
8
some
o'clock?
echo shadows at 8 o'clock.
Here? I think it's not, I think it's mucus here inside, yeah? If you want to discriminate between a nodule and mucus, you can use contrast medium, echo contrast, but this endoscope is not available for contrast enhancement. But in case, if I'm not sure whether it's a nodule or mucus, I give contrast, and in small nodules you can see the blood flow, and in mucus there is no blood flow. So this is a possible indication, but here I don't see a nodule here. Yeah?